I am pleased to introduce Mr. Randall Hagar. Randall Hagar is currently policy consultant and legislative advocate for the Psychiatric Physicians Alliance of California. Formerly first vice president of the board of directors and chair of the California Alliance for Mental Illness Legislative Committee, now NAMI, California. He was a program director for family education and assisted in drafting key passages in both the California Mental Health Insurance Parity Act and Assisted Outpatient Treatment Act, aka Laura's Law, both statutes, and many subsequent pieces of legislation. He joins us with a lot of experience, so welcome, Mr. Randall Hagar.
All right, thank you. So on my end, I've got this meeting is being recorded. There we go. All right, and that message is still there on my screen, so I don't know if you're seeing it as well. It's a big text box that's right in the middle of this.
Yeah, and there should be an option just to click OK or stay in, or some blue button that says that's cool with me.
Oh, okay. Look at that. I did it. Okay. I told you I was technologically challenged, but hopefully I'll make up for it in the rest of the presentation. So if we could advance to the next slide, please. So I'm actually a second generation advocate. I like history, so you're going to get some of that today, but I'm going to make it relevant by tying it into the present. I am a second generation advocate. My mother was a Mental Health Association founding member in the Sacramento affiliate. And so I came home from high school and got a lot of mental health policy stuff at the dinner table. Also, because of my involvement with NAMI California, you can kind of guess that I'm a family member, and that's true. I have a son with schizophrenia. And that is an education all to itself. And it does make me a little different than many advocates, because I'm not going to be representing T-Mobile next year and Chevron the year after and whatever. I've been with either, the Alliance and the family member advocacy frame or a psychiatrist since 1997. So I've been there for a while, seen a lot, and hope to share some of that and have it make some sense to you. I call it the archaeology, but there are key landmarks. Okay, good. The archaeology of mental health policy, just a fancy way of saying a little bit of history. As I said, I'll tie that into the current framework. There's this thing called legislative intent. It's like what we do when we pass bills is pretty clearly laid out what we're trying to do, but then there's a whole idea of implementing policy. And some people say, and I think I'm one of them, that effective, successful policy is 90% implementation. So we'll talk a little bit about the successes and failures in that respect, and then some reforms that come out of the failures. So next slide, please. So you guys wanted to know, what are some of the key landmarks in mental health policy? Well, I'm going to go back to 1840 very briefly. Financing of general health and behavioral health. Behavioral health basically is about 6% of the health dollars spent in this country, pretty much, a small fraction. The whole idea of parity, means mental health should be delivered on the same terms and conditions as other kind of health, services and treatment. It's important because it hasn't always been, and probably still isn't in many really key ways. And the LPS Act is the Lanterman Petris Short Act, which brought us into the present from the days of the old state hospitals, and from an era in which providing judicial oversight, providing due process and equal protection to individuals who didn't really essentially have the ability to take care of themselves, sort of came into fruition, and the LPS Act was born. And that's kind of about the civil commitment piece and of the mental health care continuum. So next slide. So a little bit deeper dive into that. 1840s was the advent of the asylum movement. We have other, landmark points on a timeline. Out of that came community-based care. I'll explain why in a second. There was an expose about the asylum movement in the 40s, some horrific conditions at a state hospital led to a long decline in state hospital systems because they fell out of favor. We finally, stopped warehousing people in the 50s because we found treatments. So Thorazine was used as a horse tranquilizer and was found to have beneficial effects on psychotic features like hallucinations and delusions. And our first antidepressants were discovered at that point too, pretty much along the same pathways. Then we had the intellectual and cultural ferment of the 1960s, which added its own kind of flavor. LPS Act was born in 67. In 1970, we began to see what, community psychiatry, widespread availability of insurance for the average citizen, and all those kind of, threads kind of came together until we could actually fast forward and talk a little bit about the 1990s and forward. That's really more of our modern era. So next slide, please. So this will probably not be familiar to you, but you can kind of guess from the archaic language that it probably does come from a much, much, much earlier era. And if you go to the next slide, it does tell you that this was a statement made by Dorothea Dix, who actually founded pretty much single-handedly what we know as the modern state hospital movement. She was a Unitarian Sunday school teacher who stumbled on the Cambridge, Massachusetts jail and found that the mentally ill were warehoused in its basement. When families couldn't take care of them, when essentially the county of Cambridge couldn't afford care, then that's what happened. And it's not unlike some things that we find today. So next slide. So, a little bit about her, she did actually go from being a Sunday school teacher into an amazing advocate, kind of an object lesson to us all. We wouldn't have a worldwide state hospital movement essentially without her. It might have been very different and fragmented, but she essentially became the confidant of senators and congressmen and eventually President Joseph Pierce. I think it was Joseph, President Pierce. And tried to get the federal government to sell off land in order to gain money in order to fund a state hospital system. That didn't work. But a movement was born. She traveled. State hospitals sprung up in England, Scotland, France, Germany. So the United States was by no means the only country, excuse me, that developed a set of hospitals to meet the need of people in the community. Next slide, please. And community care movement was born because of a lot of excesses and very sad circumstances that eventually developed in a state hospital system in the United States, which was underfunded and essentially neglected. This expose that appeared in Life magazine, that's an actual photograph from that. It shows an older woman, absolutely stark naked, sitting on a bench, doing nothing. And that really does in and of itself tell you a lot about the conditions in state hospitals and why a community care movement was born. I don't know if you can see the photograph there in the top left corner. It says despair, and there were 16 or 18 of these photographs in Life magazine. It was kind of a photo essay on the conditions. Next slide, please. So getting much closer to the present, we did finally discover the medications. So that was 1952. So for the first time in our civilization's history and prehistory, we actually had treatments instead of warehousing to offer people. But there were other important, cultural events. Brown versus the Board of Education, was all about school segregation and separate but equal facilities for Black people as opposed to white people. And that is actually important because it introduced into popular consciousness the ideas of due process, judicial oversight, and equal protection under the law. But then in the 50s, also a little bit later on, you had intellectuals like Gregory Bateson, who was an anthropologist at Stanford, who said that really mental illness is because the mind can't hold two opposite and irreconcilable ideas in itself at the same time. And so the individual gets into a double bind and their brain breaks. So first attempt at a modern theory of what mental illness was. But then the 60s came. Thomas Szasz was a psychiatrist from Eastern Europe who had suffered under the Stalin regime, had suffered under the Nazi takeover of Europe, and he posited that that mental illness was a myth and that it was just simply a method that authoritarian regimes use for control of its citizens, or some of its citizens. At the same time, R.D. Laing was a wealthy London, England-based psychiatrist who said, well, schizophrenia is really an enlightenment of sorts. It's like an acid trip. You need to support the person going through it and let them do that. Then there was Thomas Sheff, I think also at Stanford, who was a sociologist who said this is what society calls mentally ill people, or what society calls its discards, its rejects, and those people who march to a different drummer and are outside the norm. But thankfully, most of those ideas were, interesting, if, kinda, in the day. But in 1963, John F. Kennedy proposed the Community Mental Health Clinics Act. And it was to establish 1,000 clinics throughout the country and really kick off community mental health. And the sad fact was that right off the bat, the whole idea that these needed to be fully funded to be fully effective was undercut by the fact that only funding was only provided for 400 of those 1,000 proposed. So our modern era kind of got off to a bad start, but other things were happening in our culture. Civil rights acts on general civil rights, voting, fair housing, and employment were passed again. Due process, equal protection ideas have become really firmly embedded in our culture and will have a role to play in the delivery of mental health care. The Social Security Act was in 1965, Medicare and Medicaid were established. IMD exclusion was part of that. I'll talk about that later because that has a lot to do with the shape of modern treatment. And then the LPS Act. The Lanterman Petris Short Act was a model for the rest of the nation. It took 2 years. It did introduce judicial oversight. It did introduce the whole idea of due process in the involuntary treatment of individuals who lack the capacity to take care of themselves or maybe were dangerous. So next slide. So we're getting closer to the present. Just to kind of recap here real quickly, we've been introduced to the idea of treatment law reform because before the LPS, there wasn't much in the way of treatment. All it took was 2 physicians, and they didn't need to be psychiatrists, just signing a paper that said the person needed to be in a state hospital. Because of the egregious conditions that I outlined, state hospital censuses in California and elsewhere were reducing starting from the 50s, and in California, kind of culminating in the administration of Ronald Reagan when he was governor of our state. There was a struggle to design community-based systems of care. Federal policy was that no federal dollars are going to be used for hospitalizations anymore, which meant that essentially, and we're talking psychiatric hospitalizations, we're talking about feds withdrawing money for that mode of care and leaving in their stead states with the exclusive responsibility for funding inpatient care, which led to some very drastic contractions of even what many would say are necessary numbers of beds in the communities. And parity hadn't yet quite become an issue in these early days, but it would as managed care proliferated in the United States. And California for many years has led the nation in having the highest degree of penetration of managed care into the private commercial market. So we're kind of a test case, if you will, for reforms that make sure that parity, the delivery of healthcare is not done in a discriminatory way. And that's the key there, discrimination. So those are all the trends that sort of focus on the present. Let's go to the next slide. As we started to gain experience right after the LPS and the closing of the state hospitals, we noticed that there were more and more people with severe mental illness showing up in jails and prisons. State hospitals slowly became forensic focused because so many people in the jails couldn't handle them, same with the prisons. So state hospitals slowly, instead of disappearing, actually repurposed and became forensic based to take the overflow or those that could not be treated successfully in other penal institutions. And there was a lot of homelessness, a lot of arrests. People started wandering the streets. And it's not uncommon today to see that, but this really got its start in the 70s. Many statutes were added to the LPS and otherwise that tried to correct some of these measures, but we've been on a trajectory for many, many years since the 70s to try to address both the high arrest rates of people with mental illness as well as the high degree to which they appear in censuses of people with homelessness. And at the same time, managed care model spreads. As I said, California has the distinction of being a very managed care kind of state. And that has implications for care as well. So going forward to the next slide. Different things happen there. I won't go into this too much. But we started to get interesting brain, studies from NIMH when imaging was really in its early years and we could actually see the brain functioning or not functioning and how it functioned, and sometimes in real time, like with functional magnetic resonance imaging. States started to try to get out of the business just like the feds did in the delivery of mental health care and something called realignment. So in California, counties really control the action, and there are 58 counties, so you get 58 different versions of what mental health treatment looks like. Managed care consolidation, capitated payments became, terms of art that were used in both the public and private systems. We had lawsuits, Coleman case, prisons, providing, constitutionally inadequate care. And it's costing us all a lot of money. 1996, Pacific Research Institute in San Francisco pegged the costs of criminalization at 1.6 billion per year just in California. So here we go. I think this brings us very close to the present. So in response to most of these trends, we've got legislators who are really interested in doing something. They had been attempting things, as I said earlier, in the 70s, in the 1980s, and here we are in the 90s. And we get this cluster of initiatives, policy initiatives. So specific bills establishing specific programs to meet specific needs. So mentally ill offenders, trying to reduce the amount of people in our jails and those who, are recidivists, basically go back, they push a revolving door, they get arrested over and over again. Actually, was provided $200 million, ran over about 2 to 3 years, was very successful, and then funding ran out. So end of that experiment, we found out that what worked, but we've had a real hard time getting back to funding it. Mental health insurance parity law, that's actually a law I worked on with NAMI California at that time, CAMI. And it basically did what I described earlier. It meant that the same terms and conditions had to be applied when you're talking about hospitalization, outpatient care, and medication policies for health conditions like cardiac care as they would for mental health care. And then mental health homeless outreach, a bill by Darrell Steinberg. This was also about 1999, 2000. And assisted outpatient treatment, Laura's Law, where we introduced the idea that some people were just not going to be induced to connect with and engage in services, and you needed a little bit extra. And so the idea of court ordered but outpatient based intensive services was introduced with assisted outpatient treatment. And then, we had bills that eventually led up to what is now Prop 63, the Mental Health Services Act, which pumps $2 billion into the mental health treatment system in California.
Can I ask a question here?
Yes.
Who is Laura?
Good question. Laura was actually Laura Wilcox was actually a college student home from her first year at college, working in Nevada County's Department of Mental Health as a volunteer in the front office, the intake or reception area for the county behavioral health department. And a client who had been identified as dangerous, but for whom nobody could seem to find a solution because he was actively rejecting treatment or only partially engaging. And in a pretty active state of being dangerous to himself or others, he wandered in with a gun and killed 3 employees there at the Department of Behavioral, it was mental health at that time, and then went down the street to a restaurant and continued shooting and killed and wounded some other folks. So Laura's folks, her mother and father, actually became, they could have retreated in their grief, but they dedicated themselves to mental health advocacy for the next 2 decades. And so this law was named in their honor, in their daughter's honor, really. And, that's a sad story about, many things that happen. You see bills introduced because of tragedies. This is a prime example. But I think we've managed to do some good, and Laura's Law has been very helpful in a number of ways. So there you have it. So mentioned the first bullet there. We had finally had federal legislation on parity. Its final rule in California was delayed because the state dragged its feet for 5 years. And we are not out of the woods yet. The parity issue is still a struggle even today, as that last bullet says. The health plans, we're going to spend a little time here on parity. So the health plans, eventually, stop doing things like making you pay $20 for your cardiologist visit as your copay under your insurance, but $50 for your psychotherapy session with your psychologist or maybe even your psychiatrist. And so we managed to equalize payments and some of the financial things that are quantified with numbers. Yearly caps on the amount of services you could get. If you came down with bipolar disorder, you had 2 successive hospitalizations that lasted 10 days or 2 weeks each, you would have blown through all of your benefits in those 2 inpatient stays, and you would have no further mental health benefit for the rest of whatever the term was, probably the year. And so Parity actually came about because of, circumstances like that, and what was meant to correct them. So copays, annual limits, policies about pre-existing conditions, they all had to be the same under the Parity laws. So WIT actually showed us that we thought we'd made progress. That bullet about health plan audits showed that we'd made some progress. We didn't. We were able to quantify that, yeah, people were paying the same copay for their primary care doc as they were to meet with their psychiatrist, and so that was good. That was part of the whole aim of the exercise. But this WIT case kind of blew us all out of the water because it's actually still ongoing. It was decided almost 2 years ago, and the WIT court, the judge in this court, found that United Behavioral Health had actually cooked the books on every single treatment that it offered. So you have, standards for treatment for depression, for people who are suicidal, for people who are leaving the hospital after a stay because you were suicidal, for kids, for eating disorders, there's a huge list of treatment guidelines. And the judge actually found that United Behavioral Health had altered what were before the alteration nationally recognized treatment standards promulgated by organizations like, nonprofits, professional organizations like the American Psychiatric Association, and found that United Behavioral Health had done so in ways that prevented treatment. And this is a gross oversimplification because the court opinion reads 100 pages, but to benefit their bottom line, solely to benefit their bottom line. Something that many of us suspected, but we had no idea. And to have this evidence, evidence presented in court and, presided over by a judge who made these findings was pretty staggering. So our job in Parity in trying to make, equitable treatment available to people, the right service at the right time in the right location, has been a struggle in the mental health field. And so SB 855 was kind of an outgrowth of that, and it basically incorporated the findings of the WIT court that said, you had to use nationally recognized standards, you could not alter them, and you needed to pay attention to the chronicity of illnesses like depression, when they were in fact not just acute episodes, but they were chronic, and not put restrictions or limitations on the provision of those kinds of services. And there were a whole other long list of things that the court ordered United Behavioral Health to alter and or to do so that it was in compliance with the 2008 Mental Health Parity and Addiction Act, as well as the state parity statute. So I'm going to stop at that point because people may have questions, and I want to make sure that those questions are answered at this point before I move on.
Yeah, so Reese and I both have our eyes on the chat box. We want to encourage folks, if you have questions as we're moving through this is a really good historical detailing of major pieces of legislation that has brought us to where we are today. If you have questions, ask them. I haven't seen any questions drop in the chat box yet, though, Mr. Hagar. So,
okay.
Yeah.
Well, from this point forward, I'm going to stop my rapid fire delivery, and I'll be a little more, less rapid in my delivery. So a lot of information here, but I figured you needed a good grounding. If you come away with the themes here, then I think you're doing well. So we've got parity kind of figured out under our belt and somewhat described. We also now turn to the civil commitment, more specifically the pieces of the Lanterman Petris Short Act that are are important, as important today as they were in 1967 when it was enacted. So it's a whole bunch of code sections, as you can see. It sets out the parameters of emergency and or crisis care. And it is about involuntary treatment. You don't need these kind of due process protections if you're talking about people who are voluntarily, saying, I need help. That presents its own problems because of the lack of hospital beds, the lack of psychiatrists, and the way our systems still struggle to deliver adequate care. But the LPS is really about the people who are either, a danger to themselves, danger to others, or are gravely disabled to the extent that they cannot provide for their own basic needs like food, clothing, and shelter. So in setting out a system to deal with these issues, the legislature made pretty clear what its intent was. And this is where we go back to the theme I introduced in one of the first slides, which is, this is legislative intent, and it's all well and good. And this is really good stuff. I mean, who wants to be indefinitely committed? Nobody. So legislative intent said, end indefinite commitments. That's what we're intending to do. That's what these code sections are about. And also to provide prompt evaluation and treatment. We don't want people languishing in institutions, waiting for months or years for possible treatment. We also know that one of the unfortunate facts is that we do have dangerous individuals simply because of their mental illness, and more than likely because it's not being adequately and may not be treated at all. So we want to protect the public, but we also want to protect these individuals because they're not managing well. They're vulnerable, they're often very fragile, and they're out in the community and they're preyed upon. And though that leads to a very high rate of victimization. So we want to prevent those individuals from suffering criminal acts. We also want to, as I've touched on, safeguard individual rights through judicial review. So I'm working on a bill right now where we're talking about what kind of evidence the judge can hear when they're considering whether or not to go from a 5150, which is the 72-hour hold, to the next hold, the 5250, which is an additional 14 days. If you continue to be dangerous to yourself or others or have grave disability. Happens a lot. And, we really want to be able to provide individualized treatment. And, this is couched for conserved individuals, but it is true throughout the act. And so that's legislative intent. I think, next slide, please, that if you look on the streets, you can still see people out there and you're wondering, they don't seem capable, they do seem gravely disabled. And so we are not taking care of people in a way that's adequate to their needs. They're not being stabilized. They're not getting consistent treatment and support, medication, all that they would need to live a stable life in the community. Like assisted outpatient treatment or Laura's Law also being updated. The statute because or you lose the authority to do it and the programs will go away. So we removed the sunset, we made it permanent. Counties could adopt it if they wanted, they didn't have to. And so we made it clear we wanted every county to do it because there was such great data. Wherever you used assisted outpatient treatment, you could get an 80% reduction in arrests among the people who would qualify. You get a 75% reduction in homelessness. You get sometimes 100% reduction in violence, either directed towards the self or to other people. And you got a lot of medication compliance. You got stable, people were able to, no surprise here, under the, conditions where the rest of those things were happening. You also had stable, people would stay stable in housing. So we did give counties an out, but the policy case was pretty clear. Counties can benefit, people can benefit from this kind of treatment. Remember, it might be court supervised, but it's outpatient. You're not in an inpatient unit. You're not in a locked care setting. You're going home to your bed at night. And so this makes it a less restricted.
Sorry, a bit of freezing here, it looks like.
I'm here.
Okay.
Can you hear me?
Yes, we lost you for a bit. So we heard that, assisted outpatient treatment is a little less restrictive than mandatory inpatient treatment, and that's where we lost you.
Okay. So, essentially there's a list of very valid reasons backed by data that says this is good public policy. So we wanted counties to do it, but if you really didn't want to do it, we'd provide you with an opt-out. And we did some other things. We tinkered with the statute a little bit to allow counties to go in together on a single program. So if you have a small county in rural Northern California, they could pool their resources and provide the program. So this is kind of an outgrowth of the things that we have learned in our long history, struggling to find adequate models and adequate resources for people in the community. So AOT is one modality. It's not one that's used with a tremendous amount of people. So a county may adopt a program and it may be for 50 people. And those 50 people are probably what you would consider high utilizers. They go in and out of the jail, in and out of the hospital. Really, kind of hard to get them to come in off the streets when they're homeless because they reject and don't want to accept any sort of help. And that would be food and clothing and shelter sometimes, as well as mental health treatment. So the struggle still goes on. There's a lot of us working. There are 30 mental health advocacy organizations in Sacramento or operating in Sacramento. And so we're still struggling with implementation. I think, this expansion of Laura's Law is a good thing. We're working on implementation of that SB 855, the parity legislation. So we're really in the thick of a lot of system improvements. But we've got, uniform application of the LPS, differs from one county to the other. And that's a real issue. And in that respect, it fails to achieve equal protection. It's a type of treatment for people who, when they benefit from it, benefit greatly, and yet we don't offer it to all who would benefit. And on the other side, we have health plans and insurers who continue to game regulators. If you'll recall my comments about, well, we figured out the copay issue where you have numbers and you can look at that pretty easily. What happened when that got well regulated was that health plans started using more stringent utilization controls. And so a lot more prior authorization, step therapy, those kind of things came into existence. So every time you make a move, there's a counter move, it seems like. And I think we're equal to that. And that's what we're engaged in today, is trying to get the plans, who, after all, are corporations that are motivated in large part by profit, because they have stakeholders called shareholders. They do pay dividends to those shareholders, and they are, for a large part, about managing the costs of care as opposed to managing the care itself. And so we've got our hands full. There's still a lot of denial of mental health treatment by plans. But I think that this 855 provides us with a really robust tool. Interesting to note, I think I mentioned that LPS was kind of a model for the rest of the nation back in the 60s. And 855 is also being considered now pretty groundbreaking and pretty much a model in the rest of the states as well. So, as goes California, so go other states. So there's some resources out there, and just want to point you at them. If you have any comments or questions, now would be the time to put them out there. Do people know about NAMI? I'm just going to continue to rattle on, but really what I'm doing is I'm waiting for questions.
So I do have a question. In regards to AB 1976, for the assisted outpatient treatment that was passed last year, in terms of the opt-out clause, which counties chose to opt out? Was it mostly rural counties that then kind of pulled resources together for an outpatient facility, or was it along political lines?
Yeah, it's a great question, and what we see is we know that there was a private poll done by the California State Association of Counties. They basically asked which counties are going to raise their hand and do it, and which counties were not. And those who indicated, there was literally a dozen, and they were smaller and they were rural counties who didn't think they could afford to do it. So, the two larger counties that had failed to do it, that do have the resources, although they might tell you they didn't, would be Sacramento County and actually Santa Clara County. And those are leaning towards implementation kind of as we speak. I think the case has been made that it's too good to pass up. You need, if costs are an issue, look at the payback in 2 years and you make back the money that you invest to set up the programs. There's good data on that. We actually have published studies that tell you that, but Nevada County, all the counties have been doing it for a long time, will tell you, you invest $1, you get $1.85 or $2 back. And that's not even counting things like emergency room costs. So yeah, it's a lot to ask. From one perspective of a small county, which is, probably very limited in the number of treatment professionals it can attract. So, it might be Shasta County, Siskiyou, Del Norte, Eureka. I mean, pretty small counties, pretty far away from the capital. There's not a big economic base there. If you go to medical school in San Francisco and you're used to having the opera right there, you're not going to find that in Eureka. So there are a lot of cultural kind of attractions that don't exist. Probably the pay rates aren't as great. Los Angeles can pay more money for psychiatrists. Humboldt County can't meet that. Mendocino County can't meet that. Tulare County, all those many counties we don't really think about a whole lot unless we drive through them for some reason, can't afford it. But we try to make the case as best we can that if they can just find the money, borrow the money if they have to. Mental Health Service Act money can be used. You get Medi-Cal reimbursements for many of the services. There are ways to put together something that works financially.
Where do you hope this discussion around parity moves? You highlighted that there's still a lot left to be desired even after the passage of the 2008 Mental Health Parity Act. that 855 was a really big step because it pulled from some data where we understand that mainly insurers, but also, so mainly payers have not necessarily equated the financing of the mental health system with the quality offered in the mental health system.
Yeah.
And that 855 was meant to target that. Where do you see this conversation moving?
Well, it's interesting because people talk about it. It's kind of like, well, let's see how the plans respond to this. We'll exercise some oversight. We'll work with our regulators. And depending on the response, we'll know, what our next job is. So right now we're helping the state craft the regulations to implement 855. And we want them to pay attention to things like, are they offering early psychosis intervention services? So critical and such a great new model of care. So we're trying to anticipate ways in which they may try to shirk providing a continuum of services that meet the needs of individuals that are their beneficiaries. So that would be sort of the short answer. The longer answer is, why don't we go for single payer? Cut them out. And that has a lot of appeal to a lot of people. In a practical sense, it's really difficult. I like the idea myself. I have relatives in both Canada and Great Britain, and their primary care system is really good. Specialty, maybe as good, but you got to wait a long time. For to get an MRI for a back condition may take 9 months in Britain. And so there are trade-offs there. There are practical things, lessons from other countries, but single payer is an idea. And universal, coverage, using quality indicators and a lot more data. I mean, that's another direction this could go in, is our regulators are finally getting to the point where they're sophisticated enough to be able to ask the right questions of health plans to get data and to use that data to turn around and say, we think you need to modify your operations here because, you're basically shorting people who have pre-existing conditions of care that they're entitled to. Or, you're telling us you have panels of individuals that are adequate to treat the beneficiaries who have mental health issues, but why are some people waiting 4 to 6 weeks to see a psychiatrist? That's not access to care. That's bad access to care when you really need to see someone. And same with follow-up appointments. So there is this sort of, I don't want to minimize it by calling it a dance or a game, but there is this position, counterposition, reaction, resolution, and then reaction process that goes on. And I think when I retire, there'll be other advocates that will pick up the the thread of those kinds of things and run with it. I think we're always going to need advocates.
Well, hopefully there are a few on this call. I want to thank you for being with us, Mr. Hagar. I think you outlined a lot of different points that are often not taught and unknown, even though we understand the larger ramifications of said legislation. If anyone as a medical student has been on a psych rotation, you know what a 5150 is, but we just didn't necessarily knew where that was bred or what that came from, or what the historical context was, right? So I think it's important to have this type of background in order to be the advocates that you're seeking for us to be, right? So thank you for being with us this afternoon. Feedback, we want it, give it to us. It's in our survey that's dropped in the chat box. If you're staying with us, our next session on sociocultural bias and awareness will start at 2. So thanks again.
Thank you for having me.